Good afternoon, everyone. I think all the malunion or non-union have very long story, but we will end up with the virgin cases. This is 44 years old male. He came to my clinic with difficulty in walking, and this is the appearance. I don't have the picture about the rotation, but I test that there is no significant malrotation of the lower limb. Okay, and we will go through the scanogram. There is no history of trauma. There is no history of any surgery. There is no underlying disease. He had difficulty in running or playing sports since childhood. And he came because of difficulty in walking and lateral knee pain. Okay, any concern about the appearance of the patient?
Yeah, I think this is a deformity from different pathogenesis, not trauma.
Yeah.
And unilateral overgrowth could be either idiopathic or from intramuscular hemangioma or from neurofibromatosis. And I noticed that there is some spot, maybe coviolate spot over the thigh. I don't know.
You mean
and you can see the X-ray, the first X-ray, the soft tissue.
Okay.
I noticed the soft tissue. Soft tissue actually that's under the fascia. There is some lumps. There is the lumps of hypodensity, and over there in lateral side, you see that. So I guess I don't know. I have no clue, but I guess that could be some von Requien-Hosem neurofibromatosis giganteum could be unilateral.
Yeah.
Another hemangioma, if the hemangioma, you tend to see the fibrin cut or fibrosis, but I didn't see that. So I just, it start from evaluation because this.
Yeah, this needs evaluation because if you have hemangioma, you may have bleeding, when you do the osteotomy or whatever your procedure. So I will do the MRI for this case for the whole leg on the right side, at least, to check any problem with soft tissue.
Yes, so if you look at the soft tissue, it definitely looks thicker than the opposite side.
They're right.
Yeah.
And so I would want to know the etiology. It could be just hemihypertrophy, which you get sometimes.
Yeah.
But you would want to know for sure before you did anything.
Yeah, I am concerned about this pathology as well. So I sent the patient to consult to the pediatrics and the internal medicine and we conclude that this is the hemihypertrophy of the lower limb. And we try to investigate for any associated abnormality, but we did not find anything. We did not do the MRI. So I asked my pediatrician, and he said that, go on, do the deformity correction. Don't worry about that. So what is your evaluation of this deformity and what is your plan to correct the deformities? I will go straight forward to the...
So this looks, it's a valgus deformity, which you would normally expect in the femur.
Yeah.
But here the deformity seems more in the tibia than the femur.
Yeah.
So you need to do all your lines and calculate where the deformity is.
So this is valgus, and this is all the joint line angle that we try to measure. The anatomical axis is not that easy to measure because there is like a gradually bow on the femur and tibia. But we can see that we have deformity on both tibia and femur. And the severity is more on tibia. And because of the hemihypertrophy, we have lengthened, the right side is longer, both on tibia and femur. So what is your plan for correction? You will do the tibia, only tibia, or you will do both tibia and femur? This is the first question.
Yeah, we should correct both sides. The femur is also, about 10 degrees. Tibia is also about, more than, tibia is MPTA is also about
maybe
You know,
15 or something.
Yeah, it's
15 to
14
20.
degrees.
Yeah.
So, we need to correct together. Otherwise, you will have a slope in the knee joint.
Yeah.
So for me, I correct in both sides. How about John?
Yeah, definitely. When it's the significant deformity
Yeah.
on both sides, you need to correct both sides. Yeah. That's why I said you need to calculate out where the deformity is, because valgus is very often at the knee, but here it also the tibia seems to be deformed.
So, and which one you gonna do first, or you do stage?
You do
or-
them together. If you're doing acute correction, you do it together.
Yeah. I will, this is the whole tibia and femur X-ray. And I will show you the deformities again. So this is, I try to evaluate for the apex. If we draw the normal MPTA, and if we draw the normal lateral distal tibia angles, so this is our color. So I would ask you, what is your plan to do the correction, and any method about acute or gradual
Please,
or
please.
anything?
I
Yeah.
already have that.
Okay. So the first thing is I still doubt about the diagnosis because idiopathic hemihypertrophy, usually actually just longer, but the alignment is relatively good, not as bad as this one. Okay. So, but let's take it as idiopathic, right? Hemihypertrophy. We focus on the corrections. I would do both sides.
Yeah.
I would do both sides, and my first idea now is to do the distal femur corrected, closed osteotomy at the distal femur. And the tibia side, you can see that the cora is outside of the bone. So that means actually that could be, more than just one location. So maybe because it's very bold. So if I will try to think about the possibility of, resect a segment of the bone in the middle so that I can, make a good bone contact. But before I promise to do that, I will do like a paper cutting, or I will do computer simulations, to guide me. Maybe I can guide me with some PSI or something. I can make plan on computer. So far, that's my mind. Okay, that's my idea.
How about you, Dr. Vasha?
I agree. Yes, two sides. The femur is not so difficult, right? It's just a very small amount of angle. You can do it immediately. And both you have to do together. And because of the length of the tibia is longer on the right side, so you have opportunity to allow the soft tissue to correct. And then you can do any, maybe even osteotomy two side. And then you can shorten and whatever. We have to draw, I agree with Dr. Su, that we have to draw how much that we can reduce the length. Don't forget to cut the fibula as well.
Yeah.
And then you can see that this kind of shortening, this is a shortening deformity correction. So you have opportunity. It is not, but you have to draw it anyway.
Yeah. Do we need to do the fibular osteotomy?
I think
Sure.
so. Otherwise, you cannot shorten it.
Yeah, I should come here before I do the operation.
One more thing is, the amount of the angulation is not small. If it's more than 15 to 20 degrees, if you have an acute correction, you may have a peroneal nerve palsy and compartment syndrome.
Yeah.
And so you also need to have a stamp. You can have this complication. Otherwise, I have a painful memory.
Yes.
12 years ago, compartment syndrome. I flew to the US and come back. The leg is gone. And then, lawyer came to me, the 2 years continuously. So a lot of painful memory. So anyway, this should be stamped. And then for me, I will do that, double level osteotomy, proximal and distal side. The best way is I am nailing with acute correction. So I don't mind the length, about 2 cm, 3 cm is not big problem, but the deformity should be corrected.
Yeah.
So I think CW's point about both peroneal nerve palsy and compartment syndrome is really important. I've also faced the music in a patient that was actually a total knee replacement in a very, very severe valgus. And we thought it was the lateral, the common peroneal nerve that had gone, but it turned out to be compartment syndrome because he was under epidural and so wasn't complaining of pain. And it turned out to be a compartment syndrome and his entire anterior compartment had gone off. So I think it's both these things you need to really watch out for very carefully. It may not happen anytime, but somewhere along the line it could happen, and then it's a disaster.
I want to echo the Professor O because I think we also have some complication from valgus corrections with temporary or long-term peroneal palsy. I did have one case from that, but I'm lucky it got recovered. So why I want to do the TBR shortening by two osteotomy, or segmental resection because that can reduce the length. Okay, but believe me, actually, closed wedge is much more difficult than open wedge.
Yes.
And shortening actually is relatively difficult than lengthening.
And is there any role of prophylaxis, nerve decompression, to prevent any nerve injury?
I think there is. I mean, if you're doing a severe valgus deformity, it makes sense to release the peroneal nerve before you do it.
Okay. So because everyone see that the apex or the chora is outside the bone, and we can see that the bone is obviously gradual bowing. So that means there is multiple apex, right? So this is the magnitude of the deformities. We try to make the intermediate line on the intermediate segment to know that where should we want to cut if we want to perform the double osteotomy. So this is the line that we plan to collect. And as well as the lateral view, we can notice that there is increased the slope. So we plan to do the closed wedge osteotomy as well to correct the slope of the tibia. And for the femur, if we draw the line, the magnitude it less is around 8 degrees. And so this is my plan at that time. I plan to do double osteotomy at the proximal metaphysis and the distal metaphysis, and the anterior coasting weight on the lateral view on the proximal one to reduce the sagittal plane deformity. And if I plan to do overcorrection first because he came with the lateral knee pain. It's like a HTO that we need to overcorrection. This is my plan at that time. I think at that time I did not do the fibular osteotomy, honestly, because I think that if we short the length, if we do the shortening osteotomy, and close to the joint, that means close to the proximal tib fifth joint and ankle joint, it might allow some motion without osteotomy. Maybe I'm wrong. So, and this is what I did. We did the crossing wedge osteotomy at the proximal one, and you can see that the parallel of the osteotomy plane is not parallel, that we aim to cross the anterior wedge as well. And then we try to reduce as perfect as possible and maintain with the unique cortical plate in the proximal metaphysis. And then we aim for another crossing wedge osteotomy at the distal part, and again to maintain with the unique cortical plate. And then we hope that we get better alignment compared to the preoperative. Anyway, there's still some valgus, honestly. And then we do the suprapatellar nail while we maintain the deformity with the plate. Anyway, as we listen to all the nailing in the metaphysis, we need some blocking pin because it's the bow tibia. Even we do double osteotomy, the middle segment still bow. So the proper nail position is, I cannot achieve the proper nail position. So I add the blocking pin in the distal part to get better nail position. And I think this is what I did for the tibia. And we can reduce the gap, the slope. And then this is for the tibia. What is any comment for the tibia?
I think there's still some valgus in the distal osteotomy.
Yeah, there's still some valgus. And how to to get better alignment.
Fibula osteotomy.
Yeah.
You should have fibula osteotomy. That's
Yeah.
why you cannot correct that.
Yeah. Okay. So I stopped at that time because I want to evaluate the alignment, and this is the, and this is the scanogram after we do the correction. You can still see the pelvic tilt. That means the length of the right side still longer, and he can walk, but he complained about the limb length discrepancy. Okay. And then it's still some valgus. What we should do next? This is just only 2 weeks after the first
You
operation.
haven't done the femur yet.
Yeah, femur yet.
Do we need to do any correction of the tibia?
Yeah, you can do that, but you will have a complication because you already had the osteotomy and some invasive procedure. I hate that small plate. Yeah.
Yeah,
You don't have to.
sorry.
You just make some chisel,
Yeah.
and then you can have a closing wedge osteotomy like that way. So then I do not recommend, I've seen the small plate on subtrochanter, small plate on the proximal tibia. I don't want to see that.
I'm sorry about that.
Yeah, this is the same, same request to the Korean colleague, young colleague. They like to be very perfect, but that makes infection, that makes, another problem. So for me, just make a osteotomy and some crack,
Yeah.
and then you can correct, then the fracture heal, It's like a comminuted fracture will faster healing, like
Yeah.
that. And then you still have a chance, to correct a distal femur deformity. And then, I think it's much better.
You can probably overcorrect a little bit on the distal femur to get your
Yeah.
alignment correct.
And what's your plan to correct the distal femur now? Do the nail or the
Medial
plate?
closing wedge osteotomy.
Yeah. With the plate or nail.
Where's the exact cora on the femur?
I think the cora is.
The deformity is there.
If it's near the knee, I would use a plate.
You didn't make the line on the femur. We should have a malalignment test and in the local,
Yeah, it's somewhere there.
So even you can do the, dome osteotomy in the suprapatellar area. Which one is the best implant for femur?
Plate.
Always nail. If you can correct that, retrograde nailing, that's the best. But if not, you can use the locking plate with a dome osteotomy or translational osteotomy, whatever you like.
Yeah. Okay, so I will proceed what I did. So we discussed with the patient that we want to correct into more vallus alignment, and we plan to shorten the right side as well. So we plan for closing wedge osteotomy with the nail. Yeah.
Yes, so when you correct the valgus, you automatically get some shortening. So
Yes.
you have to be sure you don't end up shortening too much either.
Yeah. I do agree that.
Yeah. So we start with the normal side that we measure the normal anatomical angle, joint line angle, and this is the shape of the normal side that we want to be the reference. Then we start with the affected part here. We use the mirror image like that, and we aim our guide wire to that supposed to be good position. And then we know that because it bend, so we use the blocking screw here in order to get the proper nail position here. And after that, we do the closing wedge osteotomy at the close to the collar. And then we use the nail to reduce the deformity. Yeah, and yes, we focus on the lateral view. So we have the translation here. It's very common to put the blocking pin to increase to improve the alignment. And this is, I think, after we do the correction of the femur. So this is what we have done in stage correction. We correct the tibia first, and then we correct the femur in order to get overcorrection of the right side of the leg. Any comment, please?
So may I ask that why didn't you use the small plate on the femur?
Oh, I forget to remove this one in the second operation.
I mean
Just
that
kidding, just kidding.
the same concept.
Yeah.
You did the femur osteotomy, but you did not use the small plate. That means that we don't need the plate.
Yeah.
Even you made a crack on
Yeah.
the medial side, so that will heal. We know that we do not have to close the wedge fragment on the femur shaft fracture or whatever area. So for me, it may be better have a dome osteotomy.
Yeah.
Yeah, it may correct a lot, even translation. So it's another way. Yeah. Anyway, the femur is very nice, and now I'm very satisfied with this.
Thank you. Finally.
John?
So,
It looks good, yeah?
yeah. Any comment on the?
Excellent.
Yeah. So I think the overall alignment is better, and actually I just did it last month, so I don't have the long-term follow-up. But we believe that the symptom of the lateral knee pain will go on, and we hope for the healing of the osteotomy. Yeah, that's all. Any
Great,
comment
thank you.
from? Yeah,
I may, so since we have 7 minutes,
yeah.
so can I see the C-arm before the femur correction? I mean before the operation. Do you check the rotational control? How do you know that the AP? Our textbook says that the less trochanter shape is a good
Yeah.
guideline,
Yeah.
but you should read the recent paper about JBJS. 1 millimeter change is about 30 degrees of a rotational change. You can have that. So another trick is
To
I
put it-
usually check the lateral proximal
Yeah.
femur. It's much better to know that the anteversion. Yeah, anteversion. So
Okay.
yeah, so sometimes you may lose that.
Yeah, thank you.
Yeah.
Yeah, that's a good trick. Or we can just put a Steinman pin, as you mentioned, right? Yeah.
Right. Okay.
So any comment from the floor? Or please, we are waiting for the pediatric surgeons.
Nice to meeting you again. So I'm
I will-
half and half. I'm pediatric half.
Me
It's
too
like a
also.
John.
Yeah.
So we are pediatric half,
Yeah,
and even the Sue.
nice to meet you. Thank you. So I actually have a question for the panelists about the prophylaxis compartment, like decompression of the compartment. As we know, like if we do lengthening nail in the tibia, some surgeon might do prophylaxis anterior or lateral compartment decompression. So I'm not sure in this case that you see we have two osteotomy site, we're afraid of that compartment syndrome. Would you recommend to prophylaxis do the compartment like decompression, or just like follow up and see if we have some problem and we come back to do it later?
Yeah, I have no clear rule over there, but if the amount of the correction is a lot, it's better to do that, the decompression, the preventive decompression of the peroneal nerve as well as the anterior compartment. Yeah.
I think I agreed. So sometimes even for a bounce, when you're doing a fibula osteotomy and using that as a graft, we do a prophylactic decompression of the compartment. So yes, in certain situations where the correction is very huge, yes.
Yeah, I do keep highly alert on the compartment syndrome for TBR corrections, especially multiple segment. But I won't do like a prophylaxis facility. I never do that. But actually, I will put the drain, to the nail to reduce the hematoma, and I will give the steroid. I give the steroid, per 12 hours for 1 day, and
the
keep
IV
observation.
Intravenous steroid or just oral?
Injection from IV.
Oh,
Yeah.
Thank you.
I never do the prophylaxis compartment release in this kind of deformity correction, but I will be highly aware.
Yeah.
Post-operatively, you have to check immediately and then follow up, reassess very often, but never do prophylaxis.
I think for valgus corrections, if it's more than 20 degrees, 25 degrees, I would do a common peroneal nerve decompression. Yeah.
Thank you so much.
Thank you.
Yeah.
we still have about 4 minutes left. I have one question for Dr. Chittawee. For the femur, I think the easiest way to correct the simple plain deformity only valgus 8 degree. For me, at first, I think about closing with osteotomy and put a plate on the medial, compression on the medial side. So I asked panelists and you, would you recommend to do the nail in this kind of deformity correction of the femur, or you can put a plate to the correction side to make sure that which one is you prefer?
So the cora here is higher. If it is very distal, yes, then we do a medial closing wedge with a plate, with a tomofix or whatever. But here the cora was much higher. That's why I asked him, where was the cora? Because if the cora is higher, then a nail is definitely a better implant.
Yes, actually, I just talked to Vajra regarding the selection of nail or plates for the femur. But I think we have the same situation. If because the lesion is higher, so I'm saying nailing is okay, good, better. But if it's close to metaphyseal junction, metaphyseal areas, I would go plate.
Yeah, I agree with that because the cora is a bit high.
Any more questions from the floor? อาจารย์ต้น
You like these sections? Audience from the floor.
All right.
Thank you,
for-
everyone. Thank you.
Thank you everyone.